for all the panelists. So this is a 43-year-old businessman, morbidly obese. His weight is around 148. His body mass index is around 49, with sleep apnea syndrome, chronic smoker, with hypertension, and of course, insulin-dependent diabetes mellitus. This gentleman sustains a low-velocity fall simply while getting out of his car, and he lands up with an ACL tear and a low-grade MCL tear. So if you were to look at the MRI report, this is what was mentioned: a high-grade ACL tear at the femoral attachment, and the low-grade femoral attachment and high-grade tibial attachment, whatever that means according to the radiologist. But clinically, yes, he did have a valgus laxity. Now, mind you, when you're examining these patients, it's very difficult to get a valgus. When you're morbidly obese, you can barely sustain the thigh. So my question to the faculty is, at this point of time, with this clinical scenario, how would you like to proceed? So we'll start from the far end. So Swapnil, if you could take this, and then we could come across to Samir.
I will make the preparation for both repair,
Okay.
ACL as well as MCL.
So primarily you would want to offer him surgery, is it?
Yes.
And you're
Once
not
control of all the parameters.
And you're not really worried about the fact that he's morbidly obese, he's practically unfit. You're not worried about the fact that you're worried about infection. I mean, how many of us would really want to jump into surgery with this kind of scenario?
If everything is getting controlled, then it's,
So you would still opt for surgery?
Yes.
And you would want to do both as a single stage, or would you like to phase it out?
First, I will go for ACL reconstruction. I will prepare both legs
Right.
to take the graft from.
Right.
First, I will go for ACL reconstruction.
Right.
After doing the ACL reconstruction, I will again reassess whether MCL is really opening up.
Right.
Okay, and if it is opening up, then I can open up the meniscus. Okay, and then see how it is, and then we can reconstruct it.
Right. So any different thoughts from any of the faculty? Kaginalkar sir?
I think ACL reconstruction should not be considered with this amount of obesity.
Okay.
This first. And
Okay.
whether this is grade 3A or grade 3B MCL instability, that I will consider. And if it is grade 3A,
Okay.
I would conserve it.
All right. So, okay, fine. So clinically, if you were to ask me, he was not opening in extension, but in flexion, he was opening up.
I would be conserving him.
You would be conserving
Initially.
him. Tapasri sir?
I think first thing is needs to have valgus stress X-rays of both lower limbs to compare.
Okay.
And I can see that you've already opted for surgery in a funny position. I don't know why.
Okay.
Then my treatment for choice would be to give him DVT prophylaxis and make a
Okay.
custom-made orthosis and treat him non-surgically unless and until he comes back for surgery. If he does, I send him to you.
Okay, so he was already there with me, so you didn't have that trouble. Sir?
Yes, I think the MCL tear could very well be managed conservatively.
Right, sir.
And one can give him a brace and later on rehab.
Right,
and
sir.
then take a call about the instability and whether it requires a
Right.
delayed surgery.
Right, sir. And Samir?
Yeah, same, conservative.
All right. So you can see even amongst the faculty there is a varied opinion, and likewise I had my apprehensions about offering him surgery, so I did go conservative with him. I had to get a customized brace because nothing was fitting him what was available off the shelf. We went ahead with a gradual progressive rehab, and the same gentleman, because of the instability, landed up with a fall, had a bimalleolar ankle. So we did go ahead and fix up the bimalleolar ankle. But this patient was smart enough to ask me that my main problem is the instability of the knee, because I've sustained the injury because of that instability of the knee. So 1 year down the line, he has persistent instability, underwent a repeat MRI. And at that point, you can see that he also has a meniscus, but we are not going to touch there. So the MCL tear is still pretty evident. How would you like to treat him now? So again, if you were to go from this side now, Samir?
Now, after 1 year, if you'll see, yet MCL has not been healed up, and now I would go ahead and do a surgery in this case.
Right.
For MCL, definitely I would go ahead and do a anatomical Laprat type of procedure in this case.
Okay.
In fact, for this, I would like to harvest the hamstring from hamstrings, and I would like to use it 2 tunnels in the femur, 2 tunnels in the tibia, and do it.
And you would be comfortable in the sense that undertaking a major procedure in a high-risk patient, you wouldn't want to keep it as short?
Now, after 1 year, his main complaints are of instability, buckling is there.
Right.
Then now I have to think something ahead. for that. Now patient is demanding for
Right.
us. Now we are not saying him. He says like, do something for me.
Right.
And even in such cases, by doing a fairly good job with anatomical Laprade procedure, fairly good he will be there.
Right. Tapasya sir, anything different?
I'd like to get his long leg scanogram X-rays done to see if his axis has deviated in any form now over the last 1 year, and he has. I would like to understand as to, with a good clinical exam, what is his instability? Is it valgus instability or is it his ACL that is unstable?
All right. So he was basically, he had rotational instability. So the pivoting was something which was worrisome for him.
Okay.
In addition to that, again, he had a residual laxity in 30-degree flexion.
Okay.
Practically could not demonstrate the anterior-posterior instability in my hands, and I would be honest about that. So my main concern was the rotational instability is what you're looking at.
So I think your best bet is that if he's affordable, do an allograft ACL for him
Okay.
using a BTB. If
Okay.
not, then harvest his quad tendon. I would not touch his hamstrings. At the end of the procedure, see if his MCL is still lax, and if I'm forced to then do something on the MCL. Otherwise, I'll just go away, preferably with an allograft ACL reconstruction for him.
All right. For want of time, I'll go ahead and tell you what did I do. So the thing was, I did go ahead and augment his MCL. I did a Danish reconstruction for the medial side. I went ahead and did an ACL using the contralateral hamstrings, augmented it. My challenge was, Dr. Tapaswi did mention that he was in a funny position. Why the funny position? Because the issue was at 90 degrees in supine position, how I would normally do my ACLs, I couldn't get him to hyperflex. So the reason was I had to get him onto the leg holder, did an ACL reconstruction for him, and then went ahead and augmented that. And this is probably 2 years down the line. The gentleman is doing fine. I did not do any other additional procedure. He does have some amount of malalignment, but my concern was looking at the high risk factors to consider the least possible with the maximum possible outcome for him. So one last question before winding this up. If I were to run across the faculty, when do you consider an acute MCL repair? Because we know that throughout the conference we've heard that MCLs normally do very well conservatively. So Swapnil, we would take that from your side. When would you consider an acute MCL repair?
Acute in type 3,
Okay.
along with cruciate's injury, then
Alright.
we will go ahead and fix it.
An isolated MCL, is there any indication?
Mostly nothing.
Mostly nothing. Kaginalkar sir?
Isolated grade 3B won't exist without ACLs. I don't think
Right.
so.
Right.
So my consideration will be grade 3B. If it is opening in extension, I will definitely repair it. Grade 3A, I conserve it.
All right. So again, for want of time, quickly. So if I were to give you a rough treatment algorithm, if you're looking at a grade 3, isolated non-op is preferred. If it's a combined, which is typically something where the posterior oblique ligament is also involved and an associated cruciate, you would think about operating. If you're looking at an acute, if you have a displaced repairable meniscal tear, yes, consider it. If you have a displaced MCL into the joint, consider an open repair. Or if there is gross disruption, as we discussed about a combined rotatory instability. Right, so I would sum at that, and thank you so much for the organizers and thank you for the panelists for the wonderful discussion.